So Brian, I don't want to put you on the spot, but I will. So the nivolumab pivotal trial is a second-line trial versus everolimus. And clearly one of the challenges that we're going to have is the integration of these checkpoint inhibitors, assuming that they turn out to have a positive outcome earlier in the course of patient's disease. How do you think that should be done? Do we have a model that is the right way? Should we combine it with a TKI? Should we give it before a TKI? I mean, we're in a bit of uncharted waters, and I'm obviously not going to hold you to any trial design, but what goes through your thought process about how to bring these agents earlier in the course? Because what we're seeing in some patients is prolonged control. And clearly that's with a toxicity profile that is acceptable. So that's clearly something that we're going to want to introduce to our patients as soon as is reasonable. So what are your thoughts about that?
So I mean, I think philosophically, as you mentioned, we'd like to move this approach into frontline, similar as IL-2. I think, you know, the folks who give IL-2, and Jan can correct me, think that if you're going to give it, you should give it first. It seems that the best data is with giving it in the front line. So by extension, I would think the checkpoint inhibitors would be the same. The way I think about it, ideally we'd have biomarkers to say, gee, this 60% of RCC is susceptible to PD-1 inhibition, and therefore they should be treated up front, and this 40% is not susceptible and should be treated with TKIs as we standardly do. We don't have those biomarkers yet. There's some being developed for PD-1, but I don't think the story is quite clear yet. I know it's not quite clear. Philosophically, I would like to uncouple TKIs and PD-1 inhibition, because the great thing about immunotherapy is that in the subset who responds, they can do so durably for quite some time off therapy, right? As my colleagues who give IL-2 have been saying for decades, right? That's the goal. And so to put them with TKIs seems counterproductive, right? We're sort of weighing them down with day-to-day side effects, unless somehow that increases the CR rate or something that I don't think is going to happen, but is possible and could be tested. But I philosophically think that patients who are susceptible to checkpoint pathway inhibition should receive it. Some may need one drug, some may need two, so there may be a dialing up and down of degree of inhibition, and then everybody else should get TKIs. Now that's easy to say, but difficult to test in a clinical trial, but that's how I think about it.
But at least that gives us a sense of where we need to move the field. I mean, I think we need to move the field in a way that is going to be paradigm changing. And although to some young clinicians it'll seem like a paradigm shift, to some of the older clinicians it might look like a revisiting of a paradigm that we were somewhat accustomed to several decades ago. So, go ahead, Jen.
Just a comment that what you're both saying, I believe, is that there may be selected patients who will respond to this approach, and it may be a more restricted group of people than would respond, say, to TKIs. But for those patients, it could be a major durable response that's off treatment, that just like what we see with interleukin-2. And we've taken 20 years to select the IL-2 candidates better, which we've been able to do. So it may take us a time to select the checkpoint pathway inhibitor patients as well.
Yeah, it's interesting. This is, again, an editorial comment from my perspective, and Jen, I know you know this data well. It turns out that in 2014, the percentage of patients that have responses to IL-2s in the same 20 to 25% range as the percentage of patients responding to the checkpoint inhibitors. We'll have to wait to see how that plays out vis-a-vis whether it's a similar or dissimilar population.
Yeah,
Brian?
In some of the current trials, they've allowed high-dose IL-2 failures, and I know personally we have some patients who are obviously treated elsewhere and then have come back and gone on some of the nivolumab studies, and it doesn't seem to preclude response. So whether those responding cohorts are overlapping or not, and whether, what will be the role of IL-2, once the PD-1 agents come into play, will be interesting.